Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our palliative medicine Pearl Notes. Pearl Notes are the most important components of our BNG Onexamination Pearl course. They are the cornerstone of your Mrcp preparation, and it's mandatory for the Mrcp candidates to master them completely from the beginning to the end. It's highly recommended you should start by watching the video lecture first, then go through the lecture notes. For revision purpose, you may go through the notes specially before the exam. And make sure you have revised Pearl notes as many times until you can recall them even when you are sleeping or dreaming. Hypercalcemia is a common cause of constipation in palliative care. The cancers most frequently associated with hypercalcemia are breast cancers, lung cancer, renal cell carcinoma, prostate cancer with bone metastasis, and most commonly myeloma. Constipation in a palliative care patient without history of taking any opioid drugs, the most likely underlying pathophysiology is the hypercalcemia. Hypercalcemia is most frequently associated with two conditions. Number 1, primary hyperparathyroidism. Number 2, malignancy. And for remembering the malignancy associated with hypercalcemia, we will use the mnemonic blood pressure monitor. So M for monitor and M for myeloma. And myeloma is the most common malignancy associated with hypercalcemia. Blood starts with B and L. So B for breast cancer and L for lung cancer. And pressure starts with P and R. P for prostate cancer with bony metastasis and R for renal cell carcinoma. Hypercalcemia of malignancy is a palliative care emergency and should be considered in all patients presenting with acute deterioration. It occurs in approximately 10% of patients with cancer and usually in those with disseminated cancer. Typical features include altered consciousness, fatigue, general ache, dehydration, constipation, bradycardias, and other arrhythmias. Palliative care patient presenting with acute deterioration or altered consciousness, the most likely diagnosis is the hypercalcemia of malignancy unless proven otherwise. Hypercalcemia is most commonly encountered in case of disseminated cancer, meaning metastatic cancer. Constipation is the most common GIT manifestation of hypercalcemia, but in the palliative care patient, we should always consider acute deterioration or altered consciousness as the presenting features of hypercalcemia of malignancy. Hypercalcemia is the most common life-threatening metabolic disorder associated with malignancy and should be treated as an oncological emergency. In palliative management for your Mrcp Part 2 exam, you must consider 3 oncological emergencies. Number 1, metastatic spinal cord compression. Number 2, SBC obstruction. And number 3, hypercalcemia of malignancy. There are 3 main mechanisms by which malignancy leads to hypercalcemia. Number 1, osteolytic metastasis with local release of cytokines, including osteoclast activating factors. These osteolytic metastases associated with release of cytokines are responsible for hypercalcemia in a patient with multiple myeloma or in a patient with prostate cancer having the bony metastasis. Number 2, tumor secretion of parathyroid hormone-related protein, also known as the parathyroid hormone-related peptide, which is the main pathophysiology in the development of squamous cell carcinoma as a part of paraneoplastic syndrome. Number 3, tumor production of 1,25-dihydroxyvitamin D, meaning the calcitriol. Standard management of malignant hypercalcemia usually involves administration of intravenous fluid followed by an infusion of a bisphosphonate, for example, pamidronate. Intravenous fluid rehydration in the form of IV normal saline is the most appropriate initial or immediate management of malignant hypercalcemia, which should be followed by infusion of bisphosphonate, especially the IV bisphosphonate. IV normal saline is most effective as the immediate management, and IV bisphosphonate is most effective as a part of long-term management. Pamidronate 30 to 90 mg will restore the normocalcemia in 70 to 75% cases at 5 to 7 days, and its effect should last for approximately 2.5 weeks. Adequate hydration must be maintained in order to facilitate correction of the calcium level, and blood should be rechecked 5 to 7 days post infusion of pamidronate in order to assess the maximum effect of the drug. So following the adequate hydration, we should go for the bisphosphonate, preferably the IV pamidronate. And after 5 to 7 days of treatment, we should go for the investigation with complete blood count and electrolyte, preferably the serum calcium. Constipation is common in patients with advanced cancer, particularly in those taking opioid medication with reduced oral intake and reduced mobility. Morphine causes constipation by enhancing intestinal ring contraction. This results in hypersegmentation, which in turn impairs the peristalsis. So, underlying pathophysiology responsible for morphine-induced constipation is the hypersegmentation within the intestine, leading to impairment of the peristalsis. 90% of patients taking morphine require a laxative. A stimulant, preferably contact large bowel laxative such as senna, is the most logical choice in opiate-induced constipation. Lactulose, an osmotic laxative, is usually avoided in palliative care as it can cause abdominal cramps and excessive flatulence. Co-dantremar is a combination of dantron, a stimulant laxative, and poloxamine 188, a stool softener, and is a popular choice for constipation in palliative care. However, it is licensed only for use in patients with a terminal illness and should not be given to those who are incontinent of urine or feces due to the risk of developing a dantron burn through prolonged contact with the skin. Polyethylene glycol, trade name Movicol, is the best choice with fecal or urinary continence for constipation in palliative care. So, senna is the first-line choice of treatment for the management of opioid-induced constipation. Lactulose should always be avoided in case of opioid-induced constipation in the palliative care. And regarding the management of constipation in the palliative care, we should look for the features of fecal or urinary incontinence. Polyethylene glycol is the choice of treatment if there is associated fecal or urinary continence. And if there is no features of fecal or urinary continence and patient is in the terminal phase of illness, then we can go for a trial of co-dantremar. Reduced conscious level, hallucinations, vomiting, myoclonic jars, and pinpoint pupils are the features of opioid toxicity. Reduced conscious level in the form of drowsiness and respiratory depression are the cardinal features of opioid toxicity. Myoclonic jerks and pinpoint pupil are also the common presenting features of opioid toxicity. Opioid has got P, so P for the pinpoint pupil. Alternatively, we can use another mnemonic. Morphine is an opioid drug. So M for morphine, M for meiosis, meaning the pinpoint pupil, and M for myoclonic jerks. New side effects from a patient previously stable on doses of morphine should raise the suspicion of renal injury. Myoclonic jerks are a side effects of opioids. New onset of side effects in a patient on stable dose of morphine presenting with opioid toxicity. The most likely diagnosis is the underlying renal impairment leading to opioid toxicity. Patients stable on high dose of morphine or other opioids are at risk of side effects if they develop renal impairment as the metabolites accumulate and effectively lead to an overdose. These patients' morphine should be stopped and urgent urea and electrolyte arranged to assess the renal function. So whenever morphine-induced renal impairment is suspected, the immediate next step should be cessation of morphine followed by investigation with urea and electrolyte. Morphine undergoes extensive first-pass metabolism in the liver. However, it's the plasma half-life which defines the timing of the doses. So irrespective of the extensive first-pass metabolism, the plasma half-life will determine the timing of the doses of morphine. Morphine has active metabolites which accumulate with renal impairment and can lead to opioid toxicity. Morphine is a recognized cause of pruritus in some patients. The mechanism of pruritus is complex and often involves 5-hydroxytryptamine, meaning 5-HT, and prostaglandins as well as secondary to intradermal histamine release. Multiple pathophysiology is responsible for the development of morphine-induced pruritus. However, 5-hydroxytryptamine is considered to be the predominant underlying mechanism. Changing to an alternative opioid such as oxycodone, which is less likely to cause itching, may be the most appropriate next step. So whenever patient on morphine treatment develops pruritus, we should switch on to the other formulation of opioids like the oxycodone or fentanyl. In palliative medicine, the decision to offer blood transfusion is taken very much on an individual patient basis without the existence of cut-off values or strict guidelines. Disabling shortness of breath on minimal exertion is often considered to offer blood transfusion in the hospital setting for symptom control in palliative care. The symptoms can range from fatigue, anorexia, and dizziness to shortness of breath, headache, and angina. Strict guidelines are not followed related to blood transfusion in the palliative medicine. Maximum priority is given based on the symptomatic improvement. So if there is chance of symptomatic improvement, then blood transfusion should be given in the palliative care patient irrespective of the hemoglobin level. And usually oxygen is only considered for the management of hypoxia in the palliative patient. So disabling shortness of breath or minimal exertion in a palliative patient, go for the blood transfusion instead of the oxygen administration. The risk of osteonecrosis of the jaw is much greater for patients receiving intravenous bisphosphonates in the treatment of cancer. Bisphosphonates often leads to osteonecrosis of the jaw as well as esophageal erosions. MHRA or CHM advice is as follows. MHRA is the Medicines and Healthcare Products Regulatory Agency, which is an UK-based government agency responsible for the regulation of pharmaceuticals, blood establishment, advanced therapy medical products, and the medical devices. And CHM is the Commission of Human Medicines. Risk factors for developing osteonecrosis of the jaw that should be considered are potency of bisphosphonate, highest for zoledronate, route of administration, cumulative dose, duration, and type of malignant disease, concomitant treatment, smoking, comorbid conditions, and history of dental disease. All patients receiving bisphosphonates for cancer should have a dental checkup and any necessary remedial work should be performed before bisphosphonate treatment. Regarding the dental checkup, all patients must undergo dental X-ray OPG view. However, urgent bisphosphonate treatment should not be delayed and the dental checkup should be carried out as soon as possible in these patients. All other patients who are prescribed bisphosphonates should have a dental examination only if they have poor dental health. Patients with malignancy are at a higher risk of deep vein thrombosis and pulmonary embolism and complications of anticoagulation. Low molecular weight heparin is the treatment of choice for pulmonary embolism and deep vein thrombosis in the palliative care setting. Directly oral acting anticoagulant like apixaban or endoxaban are the first line choice of treatment for the management of pulmonary embolism and deep vein thrombosis. There are few exceptions for the drugs being the first line choice of treatment for the management of pulmonary embolism or deep vein thrombosis. Number 1, in a pregnant lady. Number 2, in a patient with underlying antiphospholipid antibody syndrome. Number 3, in a patient with severe renal impairment. And number 4, in a palliative care setting. In all the 4 conditions, we should go for the low molecular weight heparin. Low molecular weight heparin is also indicated in case of sagittal sinus thrombosis. Hyoscine butyl bromide is an antispasmodic agent which can be given subcutaneously, which makes it an excellent choice of analgesic in bowel obstruction in the palliative care. Hyoscine butyl bromide is usually the first line choice of treatment in the management of biliary colic or bowel obstruction or management of respiratory secretion. WHO recommendations for the management of cancer pain, which suggest analgesia should be given by the mouth, by the cloak, by the ladder. For the management of cancer pain based on the WHO recommendation, we must follow 3 protocols. Number 1, by the mouth. Number 2, by the cloak. Number 3, by the ladder. By the mouth implies using the oral route for all drugs including morphine and other opioids unless patient is vomiting, semi-conscious and has dysphagia. By the clock means persistent pain requires preventative treatment and as needed, meaning based on PRN, analgesia only is not acceptable. Number 3, by the ladder, which means the WHO analgesic ladder. By the mouth means always go for the oral medications unless there is specific contraindication. By the clock means give more preference on the persistent analgesia instead of isolated as needed or PRN protocol. By the ladder means follow the stepwise WHO analgesic ladder. The WHO analgesic ladder recommended that analgesia be given promptly in the following order until the patient is free from pain. Simple analgesics, for example paracetamol, aspirin, ibuprofen. Mild opioids, for example codeine. Strong opioids, for example diamorphine. The WHO analgesic ladder is as follows. Step 1. Non-opioid with or without adjuvant. For example, paracetamol or NSAIDs. Step 2. Combination of weak opioid and non-opioid with or without adjuvants. For example, cocodamol 30 by 500 mg. Step 3. Combination of strong opioid plus non-opioid with or without adjuvants, for example morphine, fentanyl or oxycodone. So adjuvants analgesics can be used in all steps of WHO analgesic ladder. In step 1, usually we go for the single drug along with the adjuvants, and non-opioids like NSAIDs or paracetamol are preferred. And in step 2 and 3, we should go for combination of two drugs with or without adjuvants. In step 2, weak opioid is given in combination with non-opioid, and in step 3, strong opioid is given in combination with non-opioid. So in all the steps, patient should receive non-opioids, and step 2, non-opioid plus weak opioid, and step 3, non-opioid plus strong opioid. They also recommended the use of adjuvant medications such as neuropathic agents, for example pregabalin, and antidepressants at any stage if appropriate. Pregabalin and amitriptyline are most commonly used as a part of adjuvant analgesia based on the WHO analgesic ladder. Nerve pain can be responsive to NSAIDs and opioids. Nerve pain, also known as neuropathic pain, often also has a nociceptive opioid responsive element, and hence opioids with a combination of non-steroidal anti-inflammatory drugs, meaning NSAIDs, should be tried first and used as a part of the WHO analgesic ladder. Usually pregabalin or gabapentin or amitriptyline or duloxetine are the preferred choice for the management of neuropathic pain. But as a part of WHO analgesic pain ladder, we should always go for the trial of NSAIDs and the opioids before switching on to the pregabalin or gabapentin or amitriptyline or duloxetine. So step 1 management of neuropathic pain should be similar to step 2 of the WHO analgesic ladder, followed by the neuropathic agents. Gabapentin potentiates GABA and possibly inhibits glutamate excitatory neurons, resulting in reduction in the neuropathic pain. GABA is the inhibitory neurotransmitter and glutamate is the excitatory neurotransmitter. Gabapentin will causes stimulation of the inhibitory neurotransmitter and inhibition of the excitatory neurotransmitter. And the ultimate outcome would be reduction in the neuropathic pain. Classic signs of an acute dystonic reaction include protrusion of the tongue, trismus, facial grimacing, difficulty speaking, torticollis, and oncological crisis. Usually in your exam, most frequently they will give you the clinical picture of an oncological crisis followed by torticollis. The patient's mental status and basic observations, for example heart rate and blood pressure, remain unaffected. The most common drug causes of acute dystonia are neuroleptics, for example haloperidol, levomethomazine, antiemetics, for example metoclopramide, and antidepressants, for example amitriptyline and trazodone. Management is dominated by the need to stop the causative drug, followed by the administration of either benztropine or procyclidine or diphenhydramine. Benztropine or procyclidine or diphenhydramine are the anticholinergic drugs. Metastatic spinal cord compression (MSCC) is defined as spinal cord or cauda equina compression by direct pressure and or induction of vertebral collapse or instability by metastatic spread or direct extension of malignancy that threatens or causes neurological disability. Spinal cord compression is a medical emergency. Administration of high-dose dexamethasone and urgent referral to the oncologist is the most appropriate immediate management. 16 mg dexamethasone should be offered to all patients with spinal cord compression as soon as possible after assessment, and MRI should be done within 24 hours. So for the immediate management of metastatic spinal cord compression, we should go for the IV dexamethasone, preferably 16 mg dexamethasone, followed by urgent MRI within 24 hours, followed by urgent referral to the oncologist. And if the clinical presentation is highly suggestive of spinal cord compression, then following the high-dose dexamethasone, the immediate next step should be urgent referral to the oncologist. MRI whole spine is the imaging modality of choice in cases of suspected malignant spinal cord compression. Steroids should be commenced on clinical suspicion of spinal cord compression. Diagnosis may be delayed and steroid treatment may minimize permanent damage. Urgent radiotherapy or spinal surgery is the definitive treatment. Spinal stabilization surgery should be urgently considered for patients with spinal metastasis and imaging evidence of structural spinal failure with spinal instability, patients with spinal metastasis and mechanical pain resistant to conventional analgesia, even if they have been completely paralyzed for more than 24 hours. So high-dose dexamethasone is the immediate or most appropriate initial choice of treatment for the management of metastatic spinal cord compression. And usually radiotherapy or spinal surgery is the definitive choice of treatment. Pre-treatment ambulatory function is the best determinant of post-treatment gait function in malignant spinal cord compression. 80% of patients will maintain mobility if ambulatory function is good at presentation of malignant spinal cord compression. So, for the assessment of post-surgical gait function in a patient with MSCC, the best determinant would be the ambulatory function at the time of presentation. Bisphosphonates are useful adjunct for bone pain, especially in breast cancer and myeloma. NSAIDs are usually a good first-line choice for the management of bony pain. Opiate analgesia can also be given in combination with the NSAIDs, and usually bisphosphonate are considered as the second-line choice of treatment. The beneficial effect of bisphosphonates can be delayed for up to 2 weeks and can last for 1 month, and treatments are therefore usually given monthly, typically for 6 months. So, for the adjunctive management of bony pain in a patient with underlying breast cancer or myeloma, bisphosphonates should be continued for at least 6 months. Plain X-ray is the initial investigation in the management of malignant bone pain. It should be used to calculate Merrill score to guide further future management. If the plain X-ray is negative, then consideration should be given to an MRI pelvis or hip, as even large metastasis can be missed on X-ray. Based on the Merrill's criteria, if the score is greater than 8, we should go for the prophylactic fixation. Merrill's criteria is composed of 4 parameters: site, pain, lesion, and size. The score of each parameter can be either 1, 2, or 3. Site of lesion in the upper limb with mild pain having the blastic lesion involving less than 1/3. Each of these parameters will carry 1 score. Site of lesion in the lower limb with moderate pain having mixed type of lesion and involving 1/3 to 2/3. Each of the parameters will carry 2 scores. Site of lesion being peritrochanteric with functional pain having lytic type of lesion involving greater than 2/3 of the size, each of the parameters will carry 3 scores. Anxiolytics such as benzodiazepines can be used in patients pre-chemotherapy to prevent nausea and vomiting. So, benzodiazepine is the most appropriate choice of treatment for the prophylaxis of pre-chemotherapy nausea and vomiting. And for the management of post-chemotherapy nausea and vomiting, the most appropriate choice would be centrally acting antiemetics like either ondansetron or palonosetron. And in resistant cases of chemotherapy-induced nausea and vomiting, especially in the delayed phase, dexamethasone should also be given along with the ondansetron. Haloperidol is the first choice antiemetic for opioid-induced nausea in the palliative care setting. Haloperidol acts as a central dopamine antagonist. Its action is predominantly via D2 receptor antagonism, meaning the dopamine type 2 receptor in the chemoreceptor trigger zone in the brainstem. 90% of patients taking morphine require antiemetics. Morphine stimulates D2 receptors in the chemoreceptor trigger zone. So morphine-induced nausea or other opioid-induced nausea and vomiting. The most appropriate initial choice of antiemetic in the palliative care is the haloperidol. And if the patient is in the terminal phase of illness, meaning during the last days of life, we can go for the levomethomazine. Ondansetron is a potent 5-hydroxytryptamine type 3 receptor antagonist and is useful for treating post-chemotherapy or radiotherapy-induced nausea. Cyclizine is a commonly used antihistamine antiemetic and its primary site of action is the vomiting center, which is rich in histamine and muscarinic cholinergic receptors. Cyclizine has a strong affinity for muscarinic receptors and therefore anticholinergic side effects like dry mouth, drowsiness, blurred vision, constipation are common, especially in the first few days. Fentanyl, or selective mu receptor agonist, should be used in pain management in acute renal failure for palliative care prescribing. Fentanyl and buprenorphine are the partial mu and opioid receptor agonists and are suitable in the management of severe renal impairment, especially in case of CKD stage 4 and 5. Fentanyl is a synthetic opioid extensively metabolized by cytochrome P450 enzymes in the liver and gastrointestinal tract, thus it is unaffected by renal impairment. Since fentanyl is not renally excreted, so this is the most suitable choice of analgesia in a patient presenting with acute renal failure or with severe renal impairment. Due to its extensive first-pass metabolism, it can only be given parenterally. Regarding the parenteral route, we can either go for transmucosal or transdermal or intramuscular or intravenous or subcutaneous. Regarding fentanyl, we should avoid the oral route. Buccal fentanyl lozenges have a very rapid onset of action and short half-life, so are very useful analgesic for the use of breakthrough pain and can be used safely in renal impairment. So, for the management of breakthrough pain relief in severe renal impairment, the most appropriate choice of treatment should be oral transmucosal fentanyl citrate lozenge. So fentanyl patch is more suitable for persistent pain relief and buccal fentanyl lozenge is more suitable as a part of breakthrough pain relief. Patients on large doses of morphine still in pain may benefit from switching to a transdermal preparation such as fentanyl. If maintenance therapy via a syringe driver is required to prevent seizures, midazolam 20 to 30 mg should be used. Previously, we learned two indications of midazolam in the palliative care. Number 1, management of agitation or restlessness. Number 2, in a patient with underlying Parkinson's disease or with Parkinson's plus syndrome. And now we are getting the third indication of midazolam in the palliative care. That is for the prophylaxis of seizure as a part of maintenance therapy via a syringe driver. The conversion for oral morphine to subcutaneous diamorphine is 1/3. So 60 mg of oral morphine is equivalent to 30 mg of subcutaneous morphine, which is also equivalent to 20 mg of subcutaneous diamorphine. So conversion from oral morphine to subcutaneous morphine divide by 2. Conversion from oral morphine to subcutaneous diamorphine divide by 3. And conversion from parenteral form of morphine to the subcutaneous diamorphine divide by 1.5. Opioids are very useful in the treatment of breathlessness in palliative care. Oxygen therapy is mainly used for hypoxic patients. Opioids are very effective agents to reduce the sensation of breathlessness. They reduce inappropriate respiratory drive. They rarely cause respiratory depression when used correctly. Benzodiazepines are effective agents also, but usually second line after opioids. Lambert-Eaton myasthenic syndrome, in short LEMS, a paraneoplastic disorder associated with small cell lung cancer. LEMS is not treated with the whole brain radiotherapy rather than with plasma exchange, steroids, and chemotherapy. Whole brain radiotherapy is never ever used in the management of LEMS. Remember, whole brain radiation is never ever used in the management of LEMS. As the syndrome is autoimmune, medicated treatments such as IV immunoglobulin, plasma exchange, and high-dose steroids may help, as well as treating the underlying small cell lung cancer, which is often very responsive to appropriate chemotherapy. As LEMS is a non-metastatic phenomenon, whole brain radiotherapy would not be helpful. So say no to radiotherapy in a patient with LEMS. Continuously infused opiates are the most effective and controllable parenteral analgesia in palliative situations. And this continuous infusion is often mediated by the syringe drivers. Both hyoscine and atropine, when given subcutaneously, are thought to be equally appropriate for drying up respiratory secretion in palliative care. The analgesic effect of codeine depends on its conversion to morphine by the cytochrome P450 2D6 hepatic enzyme. Up to 10% of Caucasians are cytochrome 2D6 poor metabolizers and are unlikely to derive any analgesia from it. Superior vena cava obstruction is a palliative medicine emergency. For your Mrcp Part 2 exam, always remember 3 conditions that are regarded as palliative medicine emergency. Number 1, metastatic spinal cord compression. Number 2, superior vena cava obstruction. Number 3, hypercalcemia of malignancy. The immediate management of metastatic spinal cord compression is high-dose dexamethasone, and the immediate management of hypercalcemia of malignancy is IV hydration. And for the definitive management of SVC obstruction, we need to go for the endovascular stenting. It is most commonly caused by carcinoma of the bronchus, and symptoms can come on rapidly, like presenting with facial flushing and swelling and breathlessness. If there is a high clinical suspicion, the patient should be referred to the local oncology service to confirm the diagnosis and initiate management. CT thorax is the imaging modality of choice in suspected cases of SVC obstruction. So in case of hypercalcemia of malignancy, most appropriate immediate investigation, urea and electrolyte. In case of metastatic spinal cord compression, MRI of the whole spine. And in case of superior vena cava obstruction, go for the CT thorax. Refeeding syndrome occurs as a result of shifts in fluid and electrolyte in malnourished patients receiving artificial nutrition either enterally or parenterally. Hypomagnesemia is the cardinal electrolyte disorder in refeeding syndrome. Refeeding syndrome induced severe hypomagnesemia may ultimately lead to life-threatening cardiac failure and severe muscle weakness. So in a patient with refeeding syndrome, the top and foremost priority should be supplementation of magnesium followed by stabilization of the other electrolytes. Assessment of brainstem death involves the observation that all brainstem reflexes are absent. For example, the corneal reflex. And this assessment must be carried out by two medical practitioners either together or separately. So for confirmation of brainstem death, it's highly recommended to go for observation of all the brainstem reflexes, especially the corneal reflex. All the brainstem reflex should be absent to confirm the brainstem death. And this observation or assessment or confirmation should be carried out by two medical practitioners, either combined or individually. These practitioners must be registered for more than 5 years and at least one but not both must be a consultant. Members of the transplant team are not permitted to be involved in the diagnosis of brainstem death. So remember this, members of the transplant team are not permitted to be involved in the diagnosis of brainstem death. The diagnosis must be confirmed by the separate medical practitioners who are not involved within the transplant team.